Therapeutics of the Hepatitis, Case 11. WH is a 35-year-old man who developed nausea, vomiting, anorexia, scleral icterus, jaundice, increasing lethargy, and disorientation. He is admitted to the ED, intubated, and transferred to the intensive care unit. The age is 35-year-old. The lab evaluation shows the following result: hematocrit 42%, HB 14, platelet 45,000, prothrombin time 25.8 second, control is 12 seconds, and INR is 3.8, AST 555, ALT 495, alkaline phosphatase 101. All enzymes, liver enzymes are increased. Total bilirubin 8.4 milligram. Normal is up to 1.2. So all liver enzymes was increased, PT increased, INR increased. His serologies, notably a positive IgM anti-HBC and HBV DNA. Hypertensive blood pressure is 158 by 99, bradycardia 58, respiratory distress 26. He shows sluggish pupillary response and increasing muscle tone. ICP more than 30. The normal should be within 15. What clinical finding does in this patient shows that or supports the diagnosis of acute hepatitis and acute liver failure. So all these elevated enzymes, including AST, ALT, alkaline phosphatase, total bilirubin, and positive for anti HBC and HBV DNA, and plus clinical features indicates the patient have acute hepatitis and acute liver failure. What clinical findings supports the diagnosis of hepatic encephalopathy? Patient shows the sluggish pupillary response and increasing muscle tone with increase in intracranial pressure, which is near about more than 30 millimeter of Hg, indicates indications for the hepatic encephalopathy. Design a plan for management of these patients as intracranial pressure is increased. To reduce the intracranial pressure, the drug of choice is mannitol. We have to give osmotic diuretic 100 to 200 ml of 20% solution of mannitol administered by rapid IV infusion to induce an osmotic diuretic with a subsequent decrease in the intracranial pressure and the blood pressure. And the dose may be repeated at least once after several hours. So if the patient having the ICP, the drug of choice is mannitol to decrease the elevated ICP. A platelet transfusion should be considered if his count drop less than 50,000 per cubic millimeter. And the decreased level of clotting factors second 5 7 9 10 normally synthesized by the liver and account for his prolonged pt and elevated inr. And the patient is also thrombocytopenic and risk for the gi ulcerations. Since he is not actively bleeding, fresh frozen plasma is not indicated at this time. So here the another management include prophylactic histamine 2 receptor blockers. As we discussed in the lecture of the hepatic encephalopathy, the management plan includes the histamine 2 receptor blockers to reduce the incidence of the GI hemorrhage. We have to also give the vasopressor drug to inhibits or to reduce the bleeding from the esophageal varices. So drug decreasing the portal pressure to decrease the bleeding from esophageal varices are octreotide, vasopressin, and the beta blockers. Also, we have to decrease the ammonia production by decreased dietary protein. And if the patient, so we have to treat the hepatic encephalopathy in the symptomatic way. We have to take care of the all the symptoms. So decrease the dietary protein, evacuation enema with the lactulose to take care of the constipation, neomycin, which is antifungal drug which kills the flora, probiotics, lactobacillus, good germ, and stimulation of ammonia metabolites, ornithine aspartase, same as we discussed in the lectures. There is also flumazenil benzodiazepine receptor antagonist because there is an endogenous benzodiazepine increase and the deepness of the coma. To take care of this coma, we have to give benzodiazepine receptor antagonist. If the endogenous benzodiazepine will increase, it causes the coma, and the hepatic coma is a severe advances complication of hepatic encephalopathy. And regarding the HBV, the patient has decompensated liver waiting for the liver transplantation. So you can give antiviral drugs, maybe lamivudine or adofovir, or you can give entecavir, and you can also add adofovils. So this is all about the hepatic cases of the liver hepatitis and the hepatic encephalopathy. Uh, Study this all the two lectures very carefully, and please, what should you know from the today's session? What should you know from the today's session? Just please remember interferon alpha 2a, interferon alpha 2a, interferon alpha 2a. It is indicated in the management of the chronic HBV, acute HCV, and chronic HCV infections. Second most important drug is entecavir from the nucleoside reverse transcriptase category. Third, the most important drug is tenofovir from the category of the nucleotide reverse transcriptase inhibitor category. Entecavir, tenofovir. Other drugs are the lamivudine and the adifovir, which are less efficient, having adverse resistance. So these three drugs are generally, if you see the therapeutics cases, if you have to treat the cases of the HBV, hepatitis B virus infection, and the chronic, please take care and remember about the entecavir, tenofovir, and interferon 2 alpha A. If you have to treat chronic hepatitic C virus infection, again remember interferon alpha 2A plus ribavirin plus ribavirin. Other drugs are also mentioned in the previous lecture session, so you can recall. But the most important for the hepatitis chronic C infection, remember ribavirin, and according to genotype, the most important the duration of the treatment. If the patient is from China or Asia, just remember 24 weeks of the duration, and other genotypes consider 48 weeks of the duration. If you don't know about the genotype of the patient, give maximum duration of the therapy, that is 48 weeks therapy. Ribavirin dose, it's from the 800 to 1200 milligram per day in two doses. In the two doses you have to give, and the duration of the vaccination should be 0 1 6 month. 0 1 6 month is the duration of vaccine, and if the second dose is more than 2, repeat the course. And if the third dose of the vaccine is more than 12 months, repeat the course. For the vaccine, for the prevention of the hepatitis infection, the dose is at 0 1 6 month. If the second dose is forget more than 2 months, repeat the course again. And if the third dose patient forget more than 12 months, repeat the course again. The dose for the vaccine, if the patient is more than 20 years of old, give 1 ml. And if the patient is less than 19 year of old, give the 0.5 ml, half of the dose. So this is all about the therapeutics of the hepatitis. Wish you all the best. Thank you very much.